Hey everyone, and welcome to This Explainer. I am so thrilled to have you here today. You know, as medical coders and health data professionals, you do so much more than just type numbers into a system. You are literally translating incredibly high-stakes, real-world clinical scenarios into accurate, actionable data. Today, we're diving into something deeply important: high-risk pregnancy complications. We're going to break down the exact coding guidelines, the specific terminology, and those critical clinical indicators you absolutely need to look out for in the patient's chart. But before we even look at a single code, we really have to ask ourselves this core question. When exactly does a pregnancy complication cross the line into an acute care admission? This is a high-stakes scenario. We aren't just talking about a routine checkup here. We're talking about life-altering moments where a mother and her unborn child need immediate, intensive medical intervention. Understanding that clinical reality on the ground is the key to mastering the codes we use to document it. Okay, let's dive into this. Here is our roadmap for today. First, we'll cover high-risk pregnancy admissions. Second, hypertension and pre-eclampsia codes. Third, malnutrition and social determinants. And finally, coding inpatient procedures accurately. Let's get started.
Section 1. High-risk pregnancy admissions.
So, what's the foundational rule here? Basically, an admission into an acute care facility is warranted when complications pop up that require consistent, close monitoring of the mother and fetus or specialized care. Think about the main goal. We have to keep the patient safe until the complications are brought completely under control. For instance, if a woman develops gestational hypertension, that clinical situation definitely supports admitting her to the hospital to get that hypertensive state managed. And per ICD-10-CM guidelines, the condition established after study to be chiefly responsible for occasioning the admission, that's what should be sequenced as the principal diagnosis. It's all about safety, stabilization, and intense observation.
Moving right along to Section 2. Hypertension and Pre-Eclampsia codes. Let's actually compare a couple of these states side by side. On one hand, we have gestational hypertension, which falls into our O13 category. This is pregnancy-induced hypertension without significant proteinuria. But, and this is a big but, remember your Chapter 15 guidelines, these codes require a final character to indicate the specific trimester in which the complication occurs, 1, 2, 3, or 9 for unspecified. Plus, you absolutely must append an additional code from category Z3A to specify the exact weeks of gestation. Now, a patient might be admitted here just to monitor and safely bring their blood pressure down, but clinical situations can escalate rapidly, right? Contrast that baseline monitoring with the O14.1 category, severe preeclampsia. When you see severe preeclampsia documented in the chart, an acute inpatient stay isn't just supported, it is heavily justified by the urgent, threatening nature of the condition.
What's really interesting about this is how easily we can map the physical signs and lab tests you're reading in the clinical documentation straight over to the O14 category for preeclampsia. So, if you're reading notes detailing elevated hypertension, weight gain that's way outside normal parameters, edema, which is swelling of the extremities, or maybe lab tests returning elevated albumin and creatinine in the urine, well, you know you are firmly in the O14 category. And again, when coding from O14 for these signs, always ensure your final character reflects the current trimester. But what happens when the condition reaches its absolute most critical state? That's when we look to eclampsia. The code here is the O15.0 category, eclampsia complicating pregnancy. And yes, you still must apply that sixth character for the trimester. The defining severe clinical marker you are looking for in the documentation here is convulsions. If convulsions are evident and documented, this strictly and undeniably requires inpatient status. The stakes literally couldn't be higher, and the code reflects that critical medical emergency.
All right, let's pivot a bit to Section 3, malnutrition and social determinants.
We all know that proper nutrition is absolutely critical to the health of both the mother and the developing fetus. But what happens when things go wrong? In cases where the mother-to-be is identified by the medical team as malnourished, hospitalization might actually be required so they can safely administer enteral or parenteral nutrition. When you see this real human impact documented, malnutrition in pregnancy, it's reported with a code from the O25.1 subcategory. And as always with maternity coding, it needs to be paired with the appropriate Z3A code for weeks of gestation.
Let's move to how this builds a really complete clinical workflow when you're dealing with malnutrition, our O25.1 subcategory, or any documentation supporting O9.7, which is supervision of a high-risk pregnancy due to social problems. Your job isn't quite done.
Step 2 is to actively look deeper into the chart for supporting evidence. Why? Because Step 3 requires you to report the appropriate social determinants of health codes found in categories Z56 through Z59. According to ICD-10-CM guidelines, these SDOH codes should be assigned whenever the documentation specifies that these factors are directly impacting the patient's care.
It is honestly fascinating to see the granularity of modern coding. You aren't just coding a medical diagnosis, you are capturing the patient's lived environment. The Z56 through Z59 categories require us to properly report community and housing issues that directly tie into maternal health. This includes things like homelessness, problematic housing, financial insecurity, and other broad socioeconomic factors. And here is a crucial point. ICD-10-CM guidelines actually allow coders to assign these specific SDOH Z codes based on documentation from non-physician clinicians involved in the patient's care. So notes from social workers or case managers are totally valid here. These environmental realities matter deeply to the patient's outcome, and our coding absolutely has to reflect that truth.
And finally, Section 4, Coding Inpatient Procedures Accurately.
And this brilliantly illustrates how we isolate and digest complex ICD-10-PCS terminology for treating the malnutrition we just talked about. If a pregnant woman is admitted with malnutrition and receives a nutritional supplement, you'd look at an ICD-10-PCS code like 3E0136Z. This perfectly breaks down as the introduction of a nutritional substance into the subcutaneous tissue via a percutaneous approach. It's incredibly specific, and it tells the exact story of the intervention.
Now, what about the treatments for a patient admitted with preeclampsia? These patients follow some very strict inpatient treatment protocols. You'll likely see documentation for intravenous medication administered to control their blood pressure. You'll see intravenous medication given specifically to prevent those life-threatening seizures we discussed. And you'll often see steroid injections administered to help speed up the development of the fetus's lungs. Acute care facilities must track these life-saving impacts precisely.
So to report the administration of those specific preeclampsia treatments, the IV meds and the steroids, you will use code 3E033GC. As we break that down, it stands for the introduction of other therapeutic substance into a peripheral vein via a percutaneous approach. Here, the root operation is introduction, putting in a therapeutic, diagnostic, nutritional, physiological, or prophylactic substance. It is just absolutely vital that coders accurately capture the physical act of administering these crucial interventions.
But actually, we cannot stop there. We have a final golden rule of procedure coding. As the guideline clearly states, when you report the administration of a medication or other substance, a code from the HCPCS Level 2 code set must also be reported to itemize the specific therapeutic substance that was administered. You literally must pair your PCS administration codes with the HCPCS Level 2 codes. One code tells us exactly how it was given, and the other tells us exactly what was given.
Which brings us to the end of our explainer today. I want to leave you with this final, provocative thought. When you are looking at these complex, high-risk maternity charts, balancing your O codes, your Z codes for social determinants, and pairing those PCS codes with HCPCS Level 2 codes, are you just doing data entry? Absolutely not. No way! You are the vital translator of a patient's most critical medical journey. The data you build ensures the continuity of care, it funds the facility, and it tracks the health of mothers and infants on a global scale. Thank you so much for exploring these guidelines with me today and keeping the passion for accurate data alive.